Director. Welcome to everyone in corrections. Thank you guys for allowing us to come in and provide education to you as it relates to hospice and to palliative care. Today's session is about 60 minutes long. Hopefully, I'll get through in time. But if you guys have any questions, please don't hesitate to unmute and ask questions as you need to. Of course, like I said, I'm Marquetta. You guys will be during these sessions meet Lisa Sigsworth, who also helps to provide the LNEC education, and Ann Walker as well. Everyone that's on this call or in these series are now considered a member of LMH PCO. Just remember that your login is your username. Your username is your email address, and that your temporary passcode is capital PASS1234 exclamation point. Requirements for the continuing education credit, of course, have to make sure that you have the handouts and that you attend the next 8 Tuesday sessions. And of course, when directed to do so, you'll sign in on the chat box, have to attend the entire session in order to earn this educational credit. And then, of course, following each of the sessions, you'll receive an evaluation form to complete in order to receive that educational credit. If you've attended and signed in the last week's session, you should have received that email in the evaluation to complete this morning. Of course, if you didn't, just let Jamie know. Also, you'll receive an evaluation from today's session within the next 24 hours to complete as well. And of course, video recording is available, but it's for your viewing only. Credit has to be gained by participating in this session. Today is week 3. We are going to be discussing palliative care. Here is the schedule that you guys will have for the next several weeks. Today, speaking of palliative care,
Marquetta, one thing that we do want to say is everyone should notice that next week is actually a 90-minute session as opposed to an hour session. So we will be can you go back to that slide?
Yes, I can. There
so we want to remind everyone that next week we begin at 1 o'clock rather than 1:30. Very important.
Yes. And all of the 1 o'clock sessions are highlighted there. So it's going to be next week, and then 2 weeks later, and then 2 weeks later, back to back, May 6th and May 13th. Thank you for that reminder, Jamie. Those are some of the longer sessions. So during today, we're going to describe the role of the nurse that as they provide quality palliative care for patients across the lifespan. Identify the role of the nurse collaboration within that interdisciplinary team while providing nursing care in palliative care. We're going to recognize how some health disparities, population demographics, economics, and service delivery make it necessary to improve our professional preparation for palliative care. We'll also describe the philosophy and principles of hospice and palliative care that can be integrated across settings that affects quality care for individuals that have serious illnesses. We'll also discuss some aspects of assessing physiological, psychological, spiritual, cultural, and social domains of quality of life for patients and families that have serious illnesses. A couple of people I'd like for you to meet today. Let's first meet Amy. She's a 72-year-old that has a history of diabetes, hypertension, and renal failure. Amy drives 25 miles one way every other day for dialysis. She has a 40-year-old son that's physically disabled, unable to work or drive, and lives with her. Amy has no other children as she is a widow. She's not religious, but she considers herself spiritual. 4 days ago, she had a stroke that left her left-sided paralysis. She's going to be discharged to rehab in the next few days. She doesn't have an advanced care directive or allow natural death. So I guess if we look at this, just to have a very basic conversation, if you guys, anybody wants to unmute on this, I'll just ask you, does something like this sound familiar? And of course, Amy has a lot going on. I guess the question I would ask when we start thinking about palliative care, what are some things that palliative care could actually address for Amy?
This is not just familiar, it's more often than not.
Exactly.
People tend very much to want to shy away from advanced directives.
Mm-hmm.
and they want to shy away from the idea of allowing natural death. From the standpoint of what could hospice provide for her,
Right.
certainly comfort and helping her to get some of her issues in order, uh, as long as she has the ability and the capacity to set them in order.
Mm-hmm.
We tend to put things like that off until we don't have any choice one way or the other.
Don, that's exactly right. And
And Don, I would think in the correctional setting, this is even more of an issue in terms of not knowing what the incarcerated patient might want until after the fact.
I think you're exactly right, Jamie, and I know Dr. Bell has seen this as well. Um, you know, one of the most frustrating calls I get is when I hear from a family member, uh, often a very close family member, who says, "Well, I just now found out that my son, my daughter, uh, was in that bad a shape. I didn't even realize they'd gone to the hospital. And even though it's MDOC's practice to notify, and Dr. Masters can speak to this very, very well, to notify families of the passing of a loved one, that sometimes falls through the cracks. And that's a sad position to be in. Whereas, and that's one of the things that excites me about the potential for this hospice program, working in conjunction with MDOC and Vital Core, is to try to do what we can within the restrictions that are imposed by the correctional system to enable that patient to have the kind of death they would like to have.
I know in the settings that we have in Louisiana, at least, the social workers are very much involved in trying to reconnect a lot of incarcerated patients with family members in order to get family members more involved and knowledgeable about that care.
Right.
Jamie, you're spot on. I think I don't know what the numbers are per se, but I would say that we have far more inmates who have extremely fractured, if not just totally absent
Right.
relationships with family members once they go in behind the wire.
Right.
Than you have in the free world.
Right.
So many families just cut them off.
Yep.
Yeah. One of the things I'm excited about would be that we can start early on being with palliative. We can start early on connecting those family members and having some of those conversations. So, so Cross and Bell and I are not at the last second going, hey, we need to have conversations about code status, or we've got to find family, things like that. So that's what excites me about this, is being able to start those conversations for reconciliation with family, but also for them to be able to die in the way they choose to earlier than we have been able to in the past.
Yes, ma'am. Thank you.
Very good points there. And I just wanted to kind of let you guys take a glimpse at Amy. I think I also have here another patient. Of course, she's a part of the cancer palliative care team. This is Miss Thompson. She's got stage 4 pancreatic cancer, 70 years old, retired school teacher, lives by herself. Only family lives out of state. Team follows her 8 months of treatment. When she has oncology chemotherapy, it's progressed to the point that chemotherapy will no longer have its benefit. The examples that I'm giving in these, of course, some, I'm sure you've seen sort of similarities, but the important thing when you start thinking about palliative care, and I heard someone say that, is just getting able to start early, connecting families, even with the start of palliative care versus hospice care. So as we go through this module today, maybe some of the things that I brought out in Amy and Mrs. Thompson, these patients here, I'll hopefully be able to discuss with you guys and answer any questions that you may have.
Marquetta, if I may
Yes.
share something.
Yes.
In the years that I worked in hospice, probably one of the most gratifying single events that I remember, a man that I had gone to church with for years, and he was actually diagnosed with lung cancer. We picked him up in hospice. I was talking to him one day and I said, if there was one thing that we could do to try to make this a better situation for you, what would that be? And he just looked at me and he started to well up with tears in his eyes. He said, I have been estranged from my son for nearly 40 years.
Mm.
He said, if there was some way that I could get back together with him, at least to talk to it. And we were able to put those two gentlemen back together. I was there the day that the son first came in, and they started talking, and within a matter of minutes, they were talking with each other like they had never been apart.
Right.
The
Right.
son
Wow.
visited his father every day from then until the time that he passed, and it was only a few weeks. But to know that you can enable the rebuilding of that kind of relationship it's a wonderful thing to be able to participate in.
Absolutely.
And Don, not to belabor that part, but that's true not only we find with the incarcerated patients, but also your volunteers. That you're going to be that will be training inside of those facilities. We have seen time and time again where those volunteers, because of the changing culture that takes place, those volunteers are reconnecting with their family members, and more incarcerated folks are reconnecting. It's not just this, the hospice has these secondary and third benefits to the entire facility. It's not just with the patients, but everyone that's involved in this starts to think anew about their fractured relationships.
It's the butterfly effect.
Yes,
Yeah.
sir. Yes, sir.
Yep. I certainly agree. I certainly agree. And just, as we move further into this, these sessions, we'll discover how it goes just beyond the physical aspects of caring for patients. It gets into the psychosocial, the emotional, spiritual as well. So yeah, we'll definitely hopefully touch on all of those. Thank you so much for those comments. So when we look at the nurses, they play a role in caring for those patients. They establish those goals of care. They assess and manage, coordinate the care. They're listening to the patients and the family members, being present, and also bearing witness to some of those moments that you just mentioned, Mr. Don. Also communicate with members of the team, the entire team. And of course, just by staying current with some of the evidence-based practice. Okay. Just some stats here about dying in America. About 60% of Americans live with at least one chronic condition. About 40% have two or more of those chronic conditions. And in 2022, there were over 3.3 million people in the U.S. And the top leading of those deaths were heart disease, cancer, COVID-19, of course, accident and unintentional injuries, followed by stroke and cerebral vascular diseases. When we think about the impact of care on serious illnesses, serious illnesses is defined as a health condition that carries a high risk of mortality and it either negatively affects a person's daily function or the quality of life, or it puts an excessive strain on their caregiver. So healthcare spending in the US hit $3.8 trillion a few years back. And 90% of that healthcare spending goes to treating the chronic and mental health illnesses. So misdiagnoses also complicate the development of a plan of care when we start thinking about the serious ill patients, and it also increases their financial burden. Of course, being unable to treat pain and other symptoms, that remains a major issue in healthcare because of lack of education in pain and symptom management. Of course, technology is more refined than ever before. Although it's used a lot of times to prolong life, it may not always restore life. And then, of course, just ethical issues that could include anything from inadequate communication and preparation that leads to situations that patients don't even have their wishes honored. We'll talk about that a little bit more as we move into ethics module a little later.
Before Dr. Bell and Ms. Masters and Don, what are the top diagnoses that are you all seeing inside of corrections right now? Is there, you have any typical diagnoses?
Diabetes, hypertension, heart disease, COPD.
I feel like I see cancer on the women's side, especially
Breast cancer?
all kinds of cancer.
Oh, cancer.
You know, the things that you see in the free world at large are the same things that you see inside the wire,
Right.
only much more concentrated space.
Right. Okay.
Well, when we think about chronic illnesses, you guys mentioned some of those that, and like you said, that we see on this side of the wire as well, but the side effects that are associated with, complex disease and treatments. A lot of patients that have chronic illnesses, they go unmerited or unchecked until they become, so bad to the point to where they have to, refer to hospice or to palliative care. So then it comes down to whether or not we are, prolonging life, but promoting the suffering. Or there also comes into the idea of, the burdens versus the benefits, because at one point, are we prolonging a patient's life and whether or not they're beneficial or non-beneficial? Because when you start thinking about hospice, palliative care and moving into hospice, that is definitely the idea, is to improve the quality of that patient's life. Whatever the days that they have left or the time they have left, it's important from the aspect of providing end-of-life care to concentrate on that quality. And that would include things like meeting those wishes and reuniting with family members and being able to die with a dignified death. Any questions there? Comments? Well, when we ask our question, what constitutes quality care at the end of life? Well, from a healthcare perspective, or from the teams that are providing care, they look at they found that like symptom management was one of the patient's biggest concerns. And of course, patients also wanted to discuss the emotional aspects of their disease, or what it did to them emotional to be able to go through the trajectory of disease processes. So I think that by ensuring, clear patient and family communication will help provide psychosocial support that tends to relieve pain, nausea and other distress, just being able to let them, talk about that. And from the patient's standpoint, patients want to achieve a sense of control for as long as they can. They want to have spiritual peace. They want to succeed in having everything that they need to in order. They want to be able to go back and strengthen relationships with their loved ones. And they want to believe that their life has had some type of meaning. What you see here is just the dying and illness trajectory. That first one, of course, is from a sudden and unexpected death. You'll see basically here today, gone tomorrow. These are examples of, like, car accidents, terrorism, things like that. The next one is the decline, the steady decline. That's with a short terminal phase. That would be pancreatic cancer. That could be an example there. The third one is from like chronic illnesses, a periodic crisis death, congestive heart failure, COPD, end-stage liver disease. Periodic acute exacerbation happens through that. There's also high symptom burden, and being able to prognose is challenging. The fourth is the progressive deterioration, that expected death, the lingering expected death, like frailty, such as, the patient declining but doesn't have an acute cause of death. Prolonged and gradual physical and cognitive decline with, increased fatigue or weight loss, or, they stop eating and have multiple comorbidities. And in this particular trajectory here, having caregiver support is critical. We look at, I guess from a standpoint of a survey, most adults want to die at home or in their surroundings with family and friends. Of course, this means that they depend on that family to provide care and support. And I think looking from a standpoint of, and even being in corrections, the family that the inmates have established, they are providing the care, 80% of the care. And of course, on this side, the cost of that uncompensated care equals upwards of $470 billion a year. Millennials, probably 1 out of 4 family caregivers are millennial, and over 10 million of those are caregivers. That 73% of those still work a full-time job. So they're caring for loved ones and trying to maintain a home. At this rate, caregiving can increase the risk of premature death related to stress and heart disease and things of that nature. So because those caregivers experience like physical, psychological, social, and spiritual angst. I've even had conversations with caregivers that say, I didn't ask for this, or I didn't sign up for this. And that oftentimes becomes really hard. And as members of the IDT team, we have to be able to identify what the caregiver is going through. For the volunteers in the arena that you guys are in, have to be able to identify that, these guys are caring from the heart, but we also have to keep in mind that they suffer emotional turmoil from time to time from seeing death and dying, making sure that patients' needs are met. So those are just some things that to look at that commitment and the cost, like I said, both financially and emotionally.
One of the things that became evident very quickly to me in the free world providing hospice care was what I call the sandwich effect.
Mm-hmm.
You have adults who are still raising their children, but they are also now thrust into the role of caregivers.
Mm.
So they have demands from the side of their younger children, as well as the demands of dying parents. And they are caught in between. And, that's one of the things that we were able to do in hospice, is to help relieve some of that burden. It's a little bit different, I think, on the inside of the wire. I'm kind of looking down the road to see what kind of factors are we going to see. I don't see as much of that in particular, but Jamie, as you pointed out and have a couple of times, I'm looking forward to seeing the development of the hospice volunteers as we go down this road, caring for terminally ill patients.
The buy-in that you're going to achieve is so much greater with those trained hospice volunteers in your facilities.
Exactly. What makes a family? Family what makes family for me may not be the same thing that you consider family. A lot of caregivers are family, in the population they're within, they may consider, inmates may consider themselves family, because they don't have contact with outside family. So, family goes beyond living in the same household. And of course, it varies from one country and one nationality to another. So we just have to be able to keep in mind the respectability of the fact that, patients are dying and they want those that are close to them near them. So, and then, a lot of times you're going to find that those are going to be some of the very same ones that are actually providing care to them. So it's just important to remember when we start thinking about the culture of patients, which we'll talk about that further on as well. But just remember their culture and family and some of the rituals and traditions that they hold as it relates to family and things like that. So those are things that we'll discuss as we move further on. But I dare not introduce palliative care without even having conversations about that, the culture and the whole idea of family. Other populations, of course, and I know that you guys have folks that are veterans. And then, of course, these are other populations that need more attention. That's veterans, people of color, people that identify as LGBTQ plus, people that have experienced homelessness and substance abuse disorder. In addition to that, there are also other folks that have need for increased attention. People with a history of mental health disorders also would be considered some of those that need various attention. And I guess just to think about that, having an idea as to the history of the people that you serve would be helpful in being able to provide the correct amount of attention and also as it relates to providing care.
With regards to veterans, we now have a We Honor Veterans program that we've launched throughout Louisiana and Mississippi, and we've launched it in correctional facilities as well because of the number of veterans that are there. But it does give resources to the IDT with regards to understanding particular needs of a veteran, depending upon what military experience they had.
Right.
The VA has identified, depending upon what their combat history looks like, can give you some indicators, some indications as to the disease, as well as the psychosocial issues that they're also experiencing, in addition to incarceration. So that military history has a way of coming back at the end of life to haunt a lot of veterans. And we're teaching hospices in the free world as well as inside of incarceration, how that can impact their end of life care.
Beth, I know you've seen this at CMCF. I've seen it as well. We have a couple of veterans units. And the ties that those men have together are very special ties. And I think that's something that will become incumbent upon us to try to encourage and help to foster those relationships. And I think those are going to go hand in hand with the hospice program.
Well, Don, one of the things that it was something that we just never thought of, and we started recruiting volunteers who were veterans and recruiting staff who have that sort of military experience, and making sure that those volunteers and those members of the IDT who have that military experience are connected to those patients who have who are veterans and who have a military experience as well, because there is a language among veterans that non-veterans don't enter into.
Common to them, yes.
Yes.
Point. When we start thinking about
This may be
I'm sorry, go ahead. I'm
so this
sorry.
may be laboring our thought real quick, but yes, I 100% agree that veterans have their own culture and language, but so does every other subculture within. And so being able to recognize those subcultures as well.
Yeah,
That's a
I
very
completely
good
agree.
point.
The only thing I wanted to say is that we do have a separate resource that we've been working with the VA to develop called We Honor Veterans, and it's an incredible program just around the veterans. I couldn't agree with you more. There are lots of subcultures that we see inside of hospice enrollments. It's just that the VA has helped us to develop a very good tool for, especially for veterans. That was the only point I wanted to make.
Right. So I guess defining hospice itself, of course, we know that by Medicare standards, it deals with palliative care that's provided to individuals that have a life expectancy measured in months of 6 months or less. Hospice teams, of course, provide patients and families with care, emotional, psychological, and spiritual, as well as physical, and focus on maintaining quality of life. From a historic standpoint, around the late 1960s, modern programs to care for the dying were actually organized at St. Christopher's in London, founded by Dom Cicely Saunders. And the word hospice was borrowed actually from the Middle Ages, used to designate way stations for pilgrims that were on their way to the Holy Land. The Dom Sanders actually viewed life as a journey, and just as pilgrims needed a place of support to be able to finish a journey, so patients near the end of life's journey need support in order to end their passage as well. Because hospice cares for individuals that have terminal illnesses, it's associated with death. Of course, due to things like systemic racism and marginalized care, care under a hospice program sometimes can be seen as a death sentence that leads a lot of patients away from declining. They don't want to even deal with hospice. So, that's something that we always have to consider. I remember many times working when I worked directly in hospice, one of the first things that had to be done was to alleviate the myth of hospice was sending us home and the budgets were going to be flying over the house just waiting on us to die. We had to change the trajectory of that conversation to say, we're about to do the best living that we have left to provide the quality care. So that was just getting in behind that philosophy of death, relating hospice only to death.
And this is going to be particularly sensitive inside of corrections, with some inmates thinking that, they bring in hospice so that we'll die faster, or it's going to be cheaper or whatever. This is where the importance of your trained hospice volunteers come in to mitigate those feelings by some incarcerated folks that this is a way of killing us faster.
That's right. That's right. From a standpoint of palliative care, of course, in the United States, described by that National Non-Consensus Project, it's beneficial at any stage in a serious illness. It's an interdisciplinary care delivery system. It's designed to anticipate, to prevent, to manage physical, psychological, social, and spiritual suffering, to optimize quality of life for patients and their caregivers. Palliative care can be delivered in any setting, through that collaboration of many types of care providers. It's appropriate, like I said, in just any stage of illness. So that's kind of giving you hospice, and it's also giving you palliative care. But of course, the volunteers that are in corrections that provide that hospice care, I agree with Jamie, being able to make sure that they're well trained to kind of get past that myth of thinking that any negative thoughts about hospice, because, and a lot of times when any patient accepts hospice over just allowing the disease process to take place, we find that they oftentimes stabilize because they actually get that quality care. So it's just something to consider there. Thinking about primary versus specialty palliative care or generalist palliative care. Of course, general is delivered by, not palliative care specialists. All clinicians have responsibility to get the core skills as palliative care for basic needs and to refer to a specialist if needed. Now, the difference in that and the specialist palliative care, of course, would be that's delivered by an interprofessional team that specialize or have special education and training in palliative care. I guess if I were going to give an example between these two, I would say, example would be a clinician that manages like uncomplicated high blood pressure, or yet the more complex cases would be referred over to a cardiologist. If I can show you that example to kind of show you the difference between the primary versus specialized palliative care. Here, this is just a snapshot of some stats. The 72% of the U.S. hospitals have 50 or more beds, palliative care programs. 94% of hospitals with 300 beds have more palliative care teams, and 86% of the freestanding children's hospitals with 50 or more beds report having a pediatric care team. I guess when we think about providing quality care in serious illnesses, these are some of the barriers, just being able to understand the limitations of healthcare, the inadequate palliative care training for professionals. Of course, those workforce shortages of palliative care specialists in all disciplines constantly need more research so that they could provide better care. And of course, the delayed access to palliative care or hospice services. So this is from the standpoint where we stand, but just again, getting back to knowing and understanding that, as we know and learn and we teach even in corrections, we would desire to be able to provide hospice care earlier to increase the quality of care, the quality of life for patients. Just being able to give the providers the language to use, build those collaborative relationships within a palliative care team, and of course, institute automatic triggers for, palliative care consults. That, of course, has the benefit of helping providers more objectively identify those patients that might benefit from consultation. When we start thinking about, being able to prognose or provide a prognosis, just realize, of course, it's a process and it evolves. There's not a science to it, and we certainly cannot predict the exact time of death. These are some of the resources that are utilized to make the case to provide excellent palliative care. And I just want to make sure that you guys know that you can receive this actual PowerPoint session for each one of the LNEC sessions to refer back to. And of course, if ever there's any question beyond the sessions that we have, please don't hesitate to ask questions, or if I can provide further resources. But I do want to make note here that there are resources provided for social work as well as chaplains, in addition to the nurses and physicians here. The NCP guidelines just basically talks about the domains of palliative care, those processes of care, the aspects of care, the psychological needs of care, the social need aspects of care, the spiritual, religious, and existential aspects of care, culture, as well as caring for those patients at the end of life, and looking at the legal and ethical aspects of those care. And actually, we'll cover every one of these, the rest of these domains throughout these LNEC sessions. Of course, each domain that I just mentioned has the key themes of the 6 C's, and that's going to be the assessment, the care coordination, the care transitions, what the caregiver needs, the need for communication, and also the cultural considerations. Organizations, these are just some organizations that support palliative care from both the nursing and a medical standpoint as well. Like I said, resources that you could use. Sutter Health was actually an advanced care management program, and it actually has a short video that you guys actually utilize when you continue training. I would certainly also encourage you to show this to your volunteers. But just because to have an aspect of knowing what it feels as being a caregiver to those patients, being able to provide care. But from a standpoint of advanced illness management, that's just looking at the overall being able to be admitted to hospice earlier, and that gets a better response from the patient to the care that they're getting overall. And this is that video I was telling you about, that you could click on that link there and view at your discretion there.
Are you going to show that video? No.
I don't think it will. I'll try it again. Hang on one second. That's what I was trying.
You
Hang on.
have to enable your sound, remember. Under more, I think
Yeah.
it's under.
Can you hear it?
Yes.
Oh, well, it worked. Perfect.
I'm Dorothy Betancourt. I'm going to be 88 in December. I've been under Sutter care for 5.5 years.
Advanced Illness Management is a care management program that was designed for individuals with multiple chronic conditions to support those individuals and their support systems in managing their health and well-being.
I was just here home one day, and a lady called and said, I'm a nurse from a program that we call AIM, and can I make an appointment to come over and check you out and see you at the house? So I said, okay. So we signed up, made an appointment. She came, and I was really impressed with her.
When I met Dorothy, she had not started treatment yet. We really encourage patients to have goals of care and to be involved in the goals that are made. In fact, Dorothy's first goal of care was to be independent in her home, and she's independent in her home.
When looking at why person-centered care is important and why care is delivered holistically, the priorities are really focused on what that individual's goals are and helping those individuals gain confidence and independence in managing those illnesses.
And it's so helpful to kind of prepare them to walk with them through it. And in Dorothy's case, this is a perfect example. I mean, she's almost back to what she was when I first started here. She is up walking around. She's as independent as can be.
We had a concept where it was the team that cared for a patient and not one person. We also looked at some core pillars: symptom management, self-management, and supporting that patient and increasing their confidence in the self-management. Follow-up visits, making sure that we had follow-up visits after a hospitalization within 48 hours. Advanced care planning, that we focused on what the individual's goals were, and all of the care around them and the support was based on what their goals were.
I know that the AIM nurses are out there, and anytime I need them, I can call them, talk to them, ask to see someone, and I feel like I'm not alone anymore.
Some initial results that we saw were patients and families were more satisfied with the care that was delivered. We saw that providers were more satisfied with the care that they and their team delivered. We also saw a benefit in regards to individuals being able to age in their home and stay in their home as their illness progressed. We saw 50% reduction in hospitalization. We saw 98% completion in advanced care planning. We saw a significant decrease in ICU days in the last 30 days of life. And I think as long as we stay focused on delivering high quality care, we'll be able to deliver whatever payment model ends up in the future. And from our teams, we're actually seeing that our clinicians, our nurses, and our therapists are actually happier with the care that they're delivering. And they feel like this is why we got into healthcare, was to make this type of a difference. It's the difference between an individual having dignity and being able to age in the environment that they choose.
Hey, let me see if I can get out of here now.
It occurred to me while we were talking about this promotion for advanced illness management. While we're concentrating on hospice programs inside of your correctional facilities, uh, all of hospice is palliative, but not all of palliative is end of life. And I think that you're going to find opportunities to use the skills that we're going to be training your staff and your volunteers with to further care for your chronically ill patients where life expectancy is longer than what your facility will support it for hospice. We talk about hospice being a 6-month Medicare benefit, but it's important to remember whoever's paying the bill makes the rules in terms of when patients are eligible. So if you're not taking Medicare or Medicaid funding, and you have hospice, your facility, your department has to determine when's appropriate for people to come into the hospice program. But also you can expand your palliative care services to those patients who aren't terminal yet, who have that chronic condition that eventually will lead to a terminal diagnosis, but you can impact their care much further back in the trajectory of their illness.
Exactly right. This just kind of gives an idea of that quality of life model, from a physical, a psychological, social, as well as a spiritual standpoint. Of course, anybody that provides palliative care, because it's the right thing to do, but also it's a basic human right for everyone to be able to be provided these aspects of each of the pillars of care. Of course, providing palliative care in any setting is an effort to improve quality of life at the end of that life. That just means addressing the multiple dimensions of care. And I'm sure that, in the population that you serve, that you all are going to see every, if not all of, many of these different aspects of physical, psychological, social, as well as spiritual care. Of course, what can possibly bring hope in a situation, providing compassionate care to those that are facing end of life. It can be stressful for all involved. But once there's a great understanding of how palliative care augments usual or traditional treatment plans, then the palliative care team can address the other thing, the pain, the symptoms, assist with those medical decisions, also providing support to the patients, the families, and the caregivers. So hoping for the best, review treatments that may prolong life and relieve suffering, also being able to prepare for the worst, which would, what would be left undone, who would make those decisions for them, and what would their wishes be regarding aggressive treatments such as resuscitation. These are things to keep in mind, that even as we deal with palliative care, we want to be able to respect as best we can the patient's wishes and have an understanding. And I know that situation is limited in the population, but just being able to still, again, the whole idea is to be able to allow a patient to live and die with dignity. Providing culturally sensitive spiritual care to the caregiver while considering difficult ethical issues. Of course, being able to, those that provide care, those volunteers, just be able to provide support, even in the midst of making, good decisions and caring for loved ones. People that take care of ones with serious illness report that having hope allows them to find positive meaning in their situation. It assists them in accepting the impending death of, the patient that they're caring for, and also eventually being able to heal themselves. It gives words by way of assessing spiritual needs. We sometimes I think from a nurse's standpoint, being able to say, we recognize that spirituality may be similar or very different from the patient's spirituality, and asking whether or not there are any different needs spiritually that need to be addressed. And also, caring for patients from a volunteer standpoint, I guess, just knowing that it could be hard, but we have to be able to try to make it as meaningful as possible. And of course, knowing that there's no monetary reward behind this, that is done because of the desire to see someone to be able to die a good death. Some tools and resources that palliative care provides, the tools will be those assessment tools that would assess those physical, emotional, spiritual, quality of life, and again, the caregivers' outcomes. The role of a nurse in order to be able to improve the palliative care. Of course, just remembering that everything can't be fixed. Some things just cannot be fixed. Nurses are fixers by nature and making things better. So just knowing that that's not always the outcome as you relate to hospice and palliative care, but just being able to be present. That's a way of expressing that compassionate caring. Nurses are very involved in patients at the end of life, because not only are they providing care, but they're that presence, and sometimes they bear witness. The volunteers you'll find also will bear witness, because sometimes at the end of life, patients want to have conversations. And so the nurses or other members of the team, and then possibly the volunteers, may be able to become a part of some of those intimate conversations. And of course, just maintaining that realistic perspective that there is no right way to die. There's no cookbook approach to dying. Crises and difficulties happen, along with some unexpected or joys that could be found. Keeping in mind that a flexible approach is going to be essential to meet the changing needs of the patient and the caregivers. Also recognizing that quality of life is determined by the unique needs of that patient, and assist the nurse in, remaining, or the team in remaining focused on providing those goals of care. Extending palliative care across different settings. Of course, the nurse is the constant in that care. Expand the concept of healing, being able to continue to become educated, and of course, from a standpoint of understanding have an opportunity to go through Joint Commission to get that advanced certification in palliative care. Quality palliative care, it encompasses that physical, psychological, social, and spiritual aspect, includes the family as a unit of care. These are not only defining features of the nurse's role, but they also support that philosophy and principle of palliative care, as well as it reflects the dimensions within that quality of life model that I mentioned earlier. Some final thoughts. Since nurses can't practice what they don't know, have to be able to increase their knowledge. That's essential to improve patient care, being with the patient and the caregiver. Also, palliative care, just understanding that it's best provided as functioning on an interpersonal team that is, all involved, all on board to be able to provide services to that patient. Lastly, a quote by Mother Teresa: touching the dying, the poor, the lonely, and the unwanted, according to grace that we have received, and let us not be ashamed or slow to do this humble work. That concludes the PowerPoint session that I have on today. I hope that there has been some information given. I'll pause and answer any questions or comments that anyone may have.
I'm gonna ask that everybody now put your name and your email address into the chat box, please. It's real important that we're within the next 24 hours, you will see an email. If you don't see it in your inbox, check your spam folder. A lot of folks have said, I haven't received it. I said, check your spam folder and said, oh, yeah, there it is. You will be getting a survey to evaluate today's session. And with that, you have to sign into our website in order for it to register in your profile. Each one of you on today's call does have a profile. Your profile, again, your sign in is your email address. And if you haven't uh, logged in yet, your temporary password is capital PASS 1234 exclamation point. Once you get in there, you can change your password to be whatever you want. And when you sign in doing the survey, it will automatically update your profile to include your hour of continuing education credit for today. Any questions or thoughts about anything that was said today?
I would just
Just
like
wanted to let everyone know that next week will be pain management, and Lisa Sigsworth will be teaching that session, and it's 1.5 hours. So to start at 1 o'clock.
It's going to be a 90-minute session that starts at 1 o'clock. Don, you were going to say something?
I would just like to say thank you to all the people with Vital Core and with MDOC who have agreed to participate in this. I think we've got some good things that
I hold my left hand in my right to do something with it.
It's not going to be easy, especially getting the whole thing off the ground.
Right.
But from the standpoint of what we're able to accomplish and the things that we're going to learn and see, I think everybody who is involved is going to benefit from this. So thank you very much.
I think you're going to see not only primary benefits, but you're going to see lots of different types of secondary benefits that are going to come out of this training of your staff and your hospice volunteers, your incarcerated volunteers. And we look forward to again, you're not going to be doing this alone. We are a resource for you. Whenever you have issues or questions, you can contact us. We don't have all the answers, but we do have a lot of connections with other folks who have been doing the same thing you are trying to do, and they will have the suggestions for you. We will also be creating a task force on corrections, and I hope many of you will sign up to be on that task force to help us figure out what tools and what resources we can find to help you do a better job of end-of-life care and palliative care inside of correctional settings. Any other thoughts, questions before we close down today?
I would just like to say thank you very much for your effort and your time in presenting this. It's going to be valuable.
Thank you, sir. We appreciate you. We appreciate that vote of confidence.
Thank you, Dr. Bell.
Okay, well, I'm going to go ahead and